My name is Bertone. I am a research fellow with Queen Margaret University in Edinburgh, working on the Rebuild project. In this phase of our study, we're looking specifically at health financing in fragile setting and focusing more on performance-based financing, PBF as we call it. In the previous phase, we had a look in a way at PBF, but we were focusing on it as from the perspective of health workers, so looking at PBF as a health worker incentive issue. Now we're taking a broader look and looking at PBF from the perspective of a health system. So PBF is increasingly relevant at the moment because it has been implemented in many low and middle income countries and especially in sub-Saharan Africa. A literature review that we recently completed found that PBF is indeed more common in fragile setting and that fragile setting were the early implementers. So definitely there are lessons learned in looking specifically at fragile setting and trying to analyze what has happened there and why. So what we're doing here and what our study would be relevant for is not only from an academic perspective, but also for donors who are funding or considering to fund PBF, for the implementers of PBF across different settings, and especially for governments and Ministry of Health who are trying to adapt PBF to their context and to the country. In terms of key findings, what we did first was a literature review, and we found that indeed PBF is, as I said, is more common and across fragile settings, and fragile settings were the early implementers. But also we found that there are a series of features in fragile setting that may actually favor PBF. For example, there is a greater role of external donor in certain fragile setting. There is an openness to institutional reform, that it's more common in fragile post-conflict setting than in other contexts. There is a lower level of trust, and so rather than emerging despite fragility, PBF seems to be in a way favored by these fragility features. And this is for what concerns the introduction, the adoption of PBF in the early stages. But there is more mixed findings about how the fragility features affect the implementation and the effectiveness of PBF in the longer term. Then we also did a study focusing specifically on PBF in a subset of fragile settings, which is the humanitarian context. And we looked specifically at South Kivu in the east of DR Congo, at the Central African Republic, and at the Mawa state in northern Nigeria. And in these three contexts, we observed that adaptation and flexibility and pragmatism in implementation and design of PBF is really key to the survival of the schemes in these contexts that are quite dynamic and really challenging. And indeed, some principles have been codified about PBF over time and have become, in a sense, very very fossilized. But the idea of trying to copy and paste the same approach across contexts, it really should be avoided. And what our research points to is that adaptations are the key for the success and the survival of PBF. And we have identified some key modifications, both in the design and the implementation of PBF, that are common across these contexts. And we have also highlighted what factors, both in the hardware and in the software of a health system, have favored adaptation and flexibility across these settings, and therefore could be, in a way, reproduced elsewhere. And we're now also completing a series of political economy analysis of PBF in a series of fragile settings to try and highlight the policy trajectories that PBF followed in these different contexts. And for example, our preliminary results point to the fact that in Sierra Leone, one of the contexts that we looked at, the presence of external actors, but also the issue of internal divisions within the Ministry of Health and the government, and an environment with very little resources and very little capacity and skill led to the lack of ownership and appropriation of PBF by the government. And in a sense, it may explain the start, stop, start again story of PBF in that country. In Zimbabwe, there is a relatively different story in the sense that ownership was developed, even if that happened a little bit later on. And substantive changes were introduced in order to address the challenges and to adapt PBF to the specific context. However, challenges and tensions still remain in particular in terms of funding and institutionalization of PBF in the long term. Then we started looking also at PBF, as I said at the beginning, not only as a worker incentive issue, but more broadly as a health financing reform. And again, here the evidence is rather mixed, and the expectation in general should be modest. In particular, we looked at how PBF affects strategic purchasing. And we found that PBF, it remains, even in countries where it has been implemented for a rather long time, it remains one of the mechanisms for strategic purchasing among a number of them. And it has traction only on the services that it covers, and it has limited traction beyond that, and it's relatively not well integrated with the rest of the health system.